On the NCLEX blueprint, it doesn't say anything about intra-op, meaning we're not expecting questions about intraoperative care, except only for emergencies. So there's one emergency mentioned in chapter 15. So that's the one that is tested. So this is chapter 15. The only testable part here is the one emergency mentioned under anesthesia. So let's go to complications of anesthesia. All right, this is page 258, chapter 15. Malignant hyperthermia is a reaction to anesthesia, particularly general anesthesia. So what happens is the patient has a genetic disorder. We have no idea who has it. It is part of the screening though for every pre-op patient. If you remember, there were questions that there was a checklist of questions that we did in chapter 14, asking them about a previous history of surgery. So this is one of them. The patient is screened for the possibility or the risk for malignant hyperthermia because this thing is life-threatening. So how it is screened is through questions. So we ask the patient specific questions about anesthesia. Since it's inherited, meaning it's passed on, it runs in the family. So the questions won't be just about the patient. Some of the questions will also pertain to a family member, either a sibling or a parent or a grandparent will be part of the question. So simple question is, did you or any other family member have any reaction to anesthesia? Now, these may not be um, the information may not be available to the patient because they will have no idea about what a sibling or another relative may have undergone. But if the answer is yes, though, then we consider that it could have been malignant hyperthermia. So the next action after we if they say yes to a reaction to anesthesia, then the next question, of course, is to ask, do you know what that was? If they say no, then that's fine. We just note it in the pre-op checklist that yes, there was a reaction, a known reaction from either a parent, for instance. So if that's the case, then they would consider other forms of anesthesia because the trigger for malignant hyperthermia has been associated with certain certain types of anesthetics. They're listed down here. There's a PCC box. PCC stands for patient-centered care. This is one of 7 QSIN competencies. When they say QSIN, this is quality and safety in education and nursing. So these are 7 competencies that are tested on the NCLEX. Patient-centered care means you are taking into account the patient's culture, their beliefs, their preferences, okay? Meaning this is you're individualizing your care, meaning some cultures have certain differences, some ethnic groups have certain differences. So these are tested on the NCLEX. So malignant hyperthermia falls under that because this is a genetic disorder. So based on data that they collect, because there's a malignant hyperthermia association that collects data, it's been known that malignant hyperthermia is triggered by these anesthetics right here. So these 5 anesthetics all sound the same: halothane, enflurane, azoflurane, desflurane, sevoflurane. They've been known to trigger malignant hyperthermia. This last one here, succinylcholine, is a muscle paralyzer. This thing is not an anesthetic. When we undergo anesthesia, we give the patient a cocktail of drugs. It's not enough to give them simply an inhaled general anesthetic, because that all that does is put you to sleep, right? Gives you anesthesia, but on top of that, the patient will still get an opioid. And because there can be involuntary muscle movements during surgery, and we don't want that happening because the patient might end up contaminating the surgical site, or twitching and moving during surgery, we want them to be completely still. We give them succinylcholine, which is a muscle paralyzer. Any questions so far?
Nope.
Okay. I'm just adjusting the font, that way it disables the highlight button. Okay, back here. Okay, so these are again the inhaled anesthetics that has been associated with malignant hyperthermia. So again, if the patient says yes to a reaction, even not only to themselves but to a family member, then we consider that they have a high risk for malignant hyperthermia. It's not practical to test every patient because the genetic testing costs money, and this is quite rare. It doesn't really happen often. In fact, in most operating rooms, they have a kit because they're required to have a malignant hyperthermia kit. I'll show you later what that kit contains. They're required to have one so that when this thing happens, we can respond and save the patient. Okay, so all the drugs that we need to give the patient are inside that kit. So what they do is just grab that kit, put it in the grab it into and then bring it to the operating room. They expire no after 2-3 years, and they never get to use it. Okay, so this is very rare. However, it is very fatal when it does occur. So it pays to prepare just the same. So back to the what it is. So how does it kill the patient? By the term itself, it causes severe hyperthermia. The temperature reaches, look at this, 111.2 degrees Fahrenheit, or that's 44 degrees Celsius. That is a very high temperature. So that's enough to cook your brain. However, as stated here, this is a late sign though. Other conditions will lead to the patient's death. They may not even reach that temperature. They could die sooner. So the reaction starts with, it's a disorder of, it's a metabolic disorder. So the patient reacts um, by uncontrolled muscle contractions. So they react to the anesthetics mentioned earlier and the succinylcholine by having head to toe generalized muscle contraction, or specifically muscle rigidity. So if you perform this exercise, if you contract your muscles, okay, so clench your fist and your arms and put it up in the air, okay, put it forward, and then imagine holding that for nonstop, because that's what's happening to the patient. So every muscle, every skeletal muscle in the body turns rigid. And you know how our body produces heat, right? We produce heat by shivering or by muscle contraction. So the more the muscles contract, the more heat you generate. So since this is done by every single skeletal muscle in the body, you can imagine the temperature the level of the temperature that will be generated. In addition to that, there will also be an unexpected rise in the end-tidal CO2. What does this mean? End-tidal CO2 is how we detect and ensure that the patient's airway is in the right tube. During intubation, no, after intubation, we check the placement of the plastic airway. The most reliable way to check it is to check for the presence of CO2. So we put a sensor between the end of the airway of the endotracheal tube and the vent. So we put the sensor there to check for the presence of CO2. If the CO2 is between 35 to 45, then that means the tube is in the right place. It's in the trachea. Because if it's less, then it's not in the trachea. It's probably in the, well, there's only two pipes there, so it should be in the esophagus. So since this is the most sensitive indication, who is likely to detect it first? So we're in the operating room here. So the anesthesiologist initiated the anesthesia. So the patient's intubated, then we put them on the vent, and then we apply the inhaled anesthetics, and then we administer the opioid infusion, as the opioid drip, as well as the succinylcholine. So who will see the rise, the unexpected rise in CO2 levels? Is
The
it
nurse,
The nurse who monitors the
vital signs.
I forgot what they call her though.
Circulating.
Anesthetist.
all right? It's actually the anesthesiologist.
Yeah.
However,
Oh.
this thing though can occur at any time. It doesn't just start right at the beginning of anesthesia, of conduction of anesthesia. I mean induction of anesthesia. It can also occur anytime during surgery, even up to the post-op period. Even after surgery, there's still a possibility that this will develop. So this is right here. MH may start immediately after anesthesia induction, several hours into the procedure, or even after anesthesia is completed. So we have no idea when this can possibly occur. So since we don't, do the nurses still need to know this?
Yes.
Yes.
Definitely, because what if it happens post-op, right?
Yes.
Okay, all right, so that's why we're testing it. So this is the first sign, and then followed by the muscle rigidity. So if you pick up this patient's arm, it won't go back down, it will stay up. Okay, that's how rigid it becomes. So imagine contracting your muscles and never relaxing. Of course, that will cause some damage to the muscle, correct? So this will explain the myoglobinuria. So there's muscle proteins now in the bloodstream, and of course, they'll make their way into the kidneys. These are large proteins though. They can damage the kidneys. So this is one of the consequences. The patient may develop acute kidney injury. We're not done yet. So one is acute kidney injury. Of course, you already know if the patient's temperature reaches 111.2, you know what will happen to that. The other signs are, what else will be spilled into the bloodstream when muscle cells die? So it's mentioned here.
Calcium.
Yeah, calcium will accumulate.
And potassium.
Right, potassium, because as the cells die, they will spill potassium, and calcium and potassium always go together. If they're high, if one is high, the other is also high. And then you have the myoglobin there. Plus, this will lead to, because you have low oxygen now, because your CO2 level rises, so that will lead to lactic acid accumulation, right? Because now you're in oxygen debt, so therefore there will be hypoxemia, tissue anoxia. So there will be lactic acid because you're now in anaerobic metabolism. So that will increase your acidosis. And because you also have hyperkalemia, so there could be dysrhythmias. So pick which one will kill the patient here. So there's a lot. So what do we do now? So once we see this, we already suspect malignant hyperthermia. Now it's not that easy, because what if this occurs during surgery when you have the guts open and we're in the middle of a surgery? Okay, so it's not that easy. So that's why your emergency care here which is in chart 15-1. First step is to stop the anesthetic, because that's what's triggering the reaction. This usually is already there. However, if this occurs after surgery, then they will have to be re-intubated. Give oxygen, 100%, and then this is the emergency drug. So this is a muscle relaxant. This is the only one approved though for malignant hyperthermia. No other drug is recommended. So this is in the kit. So dantrolene sodium is in the kit right here. So this is the malignant hyperthermia cart. Dantrolene sodium is in there. There's normal saline in there. There's bicarbonate because we have the possibility of acidosis, right? So we need bicarbonate to neutralize the acidity. Insulin and dextrose. Do you remember this from fluid and electrolytes we did last week? Oh, no, we haven't done it yet. Never mind. We'll discuss this in a couple weeks. So this is your management for hyperkalemia. So you give regular insulin IV with 50% dextrose that will shift potassium, lowering it. Lidocaine is used for the dysrhythmias that will occur with hyperkalemia. And calcium chloride also, and this is also another intervention for hyperkalemia. Don't worry, we'll discuss these two in chapter 11. So those are what's in your kit. So what do we do with those things? So here it is. You give the dantrolene sodium, 2 to 3 milligrams. And then if possible, we stop the surgery. Of course, if we're in the middle of something, this may not be possible. So please read the rest. If termination is not possible, maintain anesthesia with another anesthetic agent. So we don't use those, the one that was currently used, which triggered the malignant hyperthermia. Okay, so we'll use some other drug, some other anesthetic. ABGs are drawn exactly for the purpose. We need to know the pH because the patient goes into severe acidosis, then we give the bicarbonate right here. If hyperkalemia, so here's the regular insulin with dextrose that will lower potassium levels. And then this is where you use the saline now. The saline is used to cool the patient internally. So we will wrap that bag of saline in ice. So we'll hang it, infuse it to the patient, but we'll wrap the bag with ice. That way we're not only cooling the patient outside, but also we're cooling them internally. Outside, we give them a blanket, so we'll put ice all over this patient. If it's a child, it's easier to put the patient in a small tub, okay? Small tub of ice, so to lower the temperature. And that's not enough. We still have to lower the patient's temperature by other internal means. So not just IV, but we put an NG tube in the patient and then put cold solutions in the stomach. We'll put a 3-way Foley and we'll irrigate the bladder also with cold saline. Okay, so they're all sterile ice saline. Okay, so we'll cool the patient inside and out. So same thing here, the NG tube, this is for the stomach lavage, and the rectal tube will also put cold water through the rectum also. We have to maintain temperature monitoring. That way we don't overcool the patient because again, that will now trigger shivering and then that will be counterproductive. The Foley will also be needed to maintain urine output. Remember, myourinuria, the patient might go into acute kidney injury. So we need the Foley to monitor urine output, urine function, kidney function. This is where the lidocaine comes in for the dysrhythmias. And we give fluids just to maintain kidney function. Again, they are at risk for kidney injury because of this myoglobin here. And hopefully this patient survives. Of course, they are critical, so they go to ICU. And of course, when all this is done, then we record the whole thing and report it to the Malignant Hyperthermia Association, which I mentioned earlier. And then now, since they had this episode, then it will be put in their medical record now that they are allergic to those anesthetics mentioned earlier. Any question on malignant hyperthermia?
So is that all we have to know for that chapter? Or
What is your question again?
is malignant hyperthermia the only thing we need to know for chapter 15?
Yes, you want anything else?
No, thank you.
No. No.
Okay, so let's go to the next chapter. Let's go to 16. So we went from pre-op, so now the patient's surgery is finished. Let's bring them now to the post-op period. The post-op period begins in the PACU. So that's the post-anesthesia care unit. It's like a critical care unit setup. In fact, critical care unit nurses can rotate to the PACU because the setup is the same. They have 1-to-1 or 1-to-2 patient ratios. The only difference is these are post-op patients, but they are critical. So they're being monitored as far as how did they tolerate surgery? Are their vitals fine? Are there any immediate post-op complications that are critical? So the PACU nurse will do a whole body system assessment, and we will continue that when we get to the floor. So I'll get straight off to the testable part. First is the handoff report. This is what's necessary in the report. Chart 16-1. So between the PACU nurse and the post-op floor nurse, so the post-surgical floor nurse, will both need to make sure these are complete. So if one misses it, the other must ask the question. So we start with, what did the patient have? What anesthesia was used? How long was the surgery? Are there any allergies? If the patient, what are the other chronic conditions that the patient may have? Did anything happen? Did anything significant happen during surgery? Are there intra-op complications, including the malignant hyperthermia? Was there blood loss? Okay, if blood loss, how much was the loss? Did the patient receive any blood transfusion post-op? What are the current vital signs? What's your kidney function? Okay, how is your urine output? What fluids are infusing? And when was the last time the patient was medicated for pain? And the rest of these special requests are, let's say, something about the family member left the phone number, okay, that they want to be called if the patient is now out of surgery. Okay, so of course we can't call them while the patient's in PACU. There's no visitors allowed in there. So they can only visit once the patient's back on the floor. So those are special requests. And then moreover, the dressings, what's covering the incision? Is it staples? Is it glue? Do we have dressings? Are there any drains? How much is the currently inside the drainage devices? Okay. Now, at any time during the report, if the receiving nurse, especially come to the vital signs part, if you're not comfortable with the patient's vital signs, will you accept the patient's transfer?
No.
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 So you can say no, okay? You can protest that. I don't think this patient belongs in my floor. Okay, so let's say you have a blood pressure that's less than 90. Does that patient sound stable to you?
No.
No. I mean, we understand there will be some hypotension. That's why they're on IV fluids, because remember, this patient was NPO, correct? So they'll continue to be NPO for a few more hours after surgery because they won't be in any rush to, the appetite's not going to be, food is not the first thing in this patient's mind. Okay, they have pain, so all they're thinking about is pain management and then, getting out of there. Let's go now to the potential complications. Now, it begins with table 16-1. After the table, though, the chapter explains each of the items listed here by system. Okay, so let's do a rundown here. So table 16-1. Most important, of course, we do ABC. So let's start with respiratory first. Any of these conditions could potentially occur. Atelectasis is lung collapse, depending on how long the patient had the surgery. Because are we turning the patient every 2 hours during surgery?
Nope.
That's not happening. So that's why also in the skin here, if you notice in the skin, patient could sustain pressure injuries. They could have a pressure ulcer. Say you have an 8 or 16-hour surgery. We're not turning this patient. Okay, so there's a possibility, and this is already included in the consent. Okay, this is one of the complications that may result. So we monitor those post-op, very important. And pneumonia, same thing. The patient's been supine for who knows how long. Pulmonary edema will result if the patient had any pre-existing cardiac disease and then they went into heart failure. So this is now secondary to this. So once they have heart failure, then you'll see pulmonary edema. A PE, because you'll learn later in chapter 36 when we discuss DVTs, that's under the second exam. There are 3 conditions that will result in blood clot formation. One is venous stasis, the other is endothelial injury, the third is hypercoagulability. The patient who had surgery has all 3, meaning there's venous stasis because is this patient going to be jumping around and walking after surgery?
No.
No. Is this patient, did this patient suffer injury to the vessels?
Yes.
You betcha. So we have probably tens of thousands of capillaries that was cut during surgery, and then a few arteries also, a few veins. So there is definitely endothelial injury here. That's the second factor in the triad. The third is hypercoagulability, meaning these are conditions that promote the condition of blood clotting. So let's say dehydration. Can this patient potentially have fluid volume deficit after surgery?
Yeah.
Yes.
Yeah, because they were NPO before surgery and they continue to be NPO after surgery. So if our IV fluids, for instance, is not enough, okay, or let's say the pump has been beeping and then the nurse wasn't paying attention to it, and so instead of the patient getting the IV fluids for hours now, it's been beeping and the nurse was, let's say, ignoring the beeping pump. All right, so that's all possible. So the patient has all 3 conditions there leading to a blood clot. So that's serious. So that's listed here. So this is if the clot becomes an embolus, and then we have the vascular complication here under cardiovascular. So that one first, and then this one next. Ventilator dependence, it's not really likely, but it's possible. Because it's not like the patient's on the vent for a long time. That usually happens if the patient was, the surgery is really long, then yeah, that's possible, but not usually. Cardiovascular with anaphylaxis, obviously the patient had allergies that we were not aware of. Anemia due to blood loss. DIC is discussed in chapter 37, that's in your 5th semester. And also, this is also mentioned in chapter 22 later in our last module before the final exam. This is a complication. What DIC is, it's not a disease. This thing is a sequelae, meaning it can result from certain conditions, some major injury to the patient, which includes trauma from surgery. So I'll give you a rundown. DIC has 2 phases. It starts with clotting and then ends up with bleeding. So what happens is the triggers, like I mentioned, are severe injuries like hemorrhage, trauma, which again, surgery is traumatic, cancer, sepsis, or ARDS, or with what's happening now, COVID-19, is also a major surgery. So COVID-19 patients may develop DIC as well. So what happens is in the first phase, the patient makes a lot of clots. By so doing, they run out of platelets and clotting factors. Once that happens, now bleeding will follow. So this can range between a few hours to 48 hours in development, and it's important to identify it. Although rare, it can happen with post-op patients. Dysrhythmias for, again, they're NPO, so there, we might have potassium imbalances here, which is quite common. In fact, it's mentioned here, electrolyte imbalances, and you'll see all these, by the way, in the paragraph, okay? I just don't want to keep scrolling up and down, so I'll discuss them all here, and I'll let you read them for yourselves on the paragraphs on your own. Between hypertension and hypotension is more likely because of the blood loss and fluid volume deficit because the patient's NPO. If that is severe, then patient could go into shock. Patient could also experience bleeding after surgery. So bleeding is not only possible during surgery, it can happen post-op. Sepsis, this has to have been existing before surgery, because if it develops post-op, it doesn't develop that fast, probably 48 hours before they go septic. The same clots that cause the PE up here can travel to the brain, so the patient may have a stroke. Neuromuscular, here's hyperthermia. We're talking about malignant hyperthermia here, or hypothermia, which is more common because have you ever heard of a operating room that is warm and cozy? Those places are freezing. Okay, plus they give you a semi-private gown and your butt is laying on a cold stainless steel table. So the patient, of course, is exposed to hypothermia. Joint contractures, if you remember in pre-op, there were positions in the surgery that I did not discuss because they're not testable. The jackknife position, depending on the site being operated on. So we put the patient on certain positions. When this happens, the patient is already unconscious at that point. So the patient can't really tell us, oh, that feels uncomfortable. Can you move my arm a little bit to the left, please? So they can't tell us. So we're positioning the patient with them already under anesthesia. So that could cause some nerve damage and even paralysis. If we position the arm or the extremity in a wrong way, or even their neck, for instance. Joint contractures are not very common because unless the surgery really lasts a ridiculous amount of time. GI complications are very common, regardless if the patient had abdominal surgery or joint surgery. Abdominal surgery, it's easy to see because you messed with the GI tract, you subjected it to trauma. In non-abdominal surgeries, the GI system still suffers because of the effects of the medication. So starting with anesthesia, opioids, the neuromuscular blocking agents, all of them are CNS depressants. They will slow down peristalsis. So you'll have a patient who's nauseous, constipated, just miserable, okay, post-op. They'll have abdominal bloating, distension, just generalized abdominal discomfort. Kidneys are exposed to injury, not only from dehydration, but possibly from the drugs that we're giving during surgery. That's why we monitor urine output to make sure we catch it early if they did suffer kidney injury. AKI will be discussed next semester, chapter 68 in your fourth semester. And finally, skin complications. I mentioned pressure injuries earlier. There could be some other wounds there. Okay, let's say we accidentally nick the patient's arm, or elsewhere, accidentally. We could sometimes the patient falls out of the table too. Um, Rare, but it has been known to happen. Other, of course, you have the incision, and later toward the end of the chapter, we'll discuss wound evisceration and dehiscence. Dehiscence is the opening of the incision, and evisceration by the term viscera. So pieces of bowel can protrude through that open incision. So obviously this occurs in abdominal incisions. Evisceration anyway. So dehiscence can occur, of course, in any surgical site, but evisceration, because we don't have any other organs elsewhere, so it's only for abdominal surgeries. So I did that. So now your responsibility is to read the paragraphs. I just want to point out a few details here. So under cardiovascular system, also here, so please know what change is reportable, because the paragraphs go into detail. So for instance, look at this. 95% below 95% oxygen saturation or below the patient's pre-surgery baseline, because later when we get to gas exchange chapters, chapter 30 and the COPD, those patients already have low oxygen saturation to begin with. So that's why they may have below 95% oxygen saturation even before surgery. So always compare it with how were they before surgery. Cardiovascular system. So this is another one. So be specific about, because not all vital signs changes fall below normal. So example, it's easy to see if it's less than 90 systolic, that's definitely hypotension. However, if the patient's blood pressure was, let's say, 145 before surgery, and then post-op, it's now 100. 100 or 110 isn't necessarily alarming, correct? Because that still falls within normal limits. But if you compare that to the pre-surgery though, that's a huge drop. So at that point, yes, it is now reportable because there is a 15 to 20 point difference. So you went from 140 to now 110. So that's over 20 point difference already. So that is now reportable to the physician. Okay, so please read the rest. All right. So you have a job to do.
Professor, is it okay if we can get the PowerPoint that you're going through?
I never use PowerPoint. This is your
And
textbook.
that's, I mean, what you have right now.
This is your textbook.
That's in the textbook. Oh,
That's the PDF version of the textbook.
This is an ebook, so if you're using a PDF, you may have different page numbers. This is the actual textbook in an electronic form.
Yeah, that's right. Okay.
I don't like PowerPoints because it distracts you. Actually, it's right. It distracts you because it drives you away from the content. Because instead of reading the content here, because how much can you pack into a PowerPoint? PowerPoints are outlined. So here's the actual material that you need for the test. All right?
Okay.
All right. So this chart is because we did the discussion on general anesthesia. Here are the specific complications arising from regional. So this is spinal or epidural. So they are at risk for respiratory depression, hypotension, epidural hematoma, and infection and spinal headache or post-dural puncture headache. For those of you who have received an epidural for childbirth, I don't know how many of you had a spinal headache after receiving one. So here is the explanation now. This is from table 16-1. So please read these on your own. I mentioned them, but it's not all. So please read them on your own. So we did discuss kidney, the GI. That's still GI. And here's the skin. All right, so I'll begin here again because the skin assessment mentioned in the table 16.1 just mentioned pressure ulcers, wound evisceration. So we'll discuss now because we need specific interventions on how to manage dehiscence and evisceration. So let's start with normal wound healing. So how does a surgical wound heal?
Primary intention.
Okay, back in fundamentals of nursing, I know you guys discussed primary, tertiary, secondary, and tertiary wound healing, correct?
Yes.
Yes.
Okay. So what type of wound is a surgical incision? Is this a wound that heals by primary, secondary, or tertiary intention?
Primary.
Primary, because we did not lose much tissue, right? We had a nice clean incision, so there was only one step to heal it because you didn't scrape. It's unlike a pressure ulcer or a shark bite or what else? An infected wound. Okay, so we have a nice clean incision here. So it's supposed to heal by primary intention. The book didn't really specify how much drainage is expected by what day. However, they did a good job of describing it generally. For instance, the sequence of the drainage. So the first drainage is expected to be bloody. So it starts bloody and then turns into serosang in the next few days. And then finally it becomes serous finally as it heals. Okay. So the amount of drainage also should steadily decline. It should not stay moderate or large amount over the third day. Okay, it's expected to decline or decrease in the amount. So look at this example, for instance. So if you see this one, is the wound healing? Is the incision healing if it continues to have still serosanguinous drainage 5 days after surgery? Is the wound healing at all?
No.
No, that's not evidence of healing. The wound is supposed to dry up by that time. Right, so there shouldn't be any more drainage there. Very little, if any, and the drainage shouldn't be bloody at all. It should be now clear at least. So that's unexpected. However, they also mention here what are expected and therefore are no cause for concern. So here's one: crusting on the incision and a pink line to the incision or around the staples. Okay, so that's fine because you have a incision, so it's supposed to look pink, okay, but not red, and it's not supposed to be swollen or tender. If any swelling is present, it should be only around where the staples or sutures are because you have a foreign object there. So of course it's going to cause some local inflammation. Okay, so once we remove the staples though, that should disappear. So it only stays there because the staple is there. There's a foreign object sticking inside the skin. So here, these are all reportable. Okay, so especially if your drainage is now multicolored or very colorful, that's not good. So if you have an orange, brownish, yellowish drainage or discharge, those are all signs of infection. So there are two problems here with the surgical incision. This usually occurs during the first 1 to 2 days of surgery. It's common in obese patients because there's not enough staples or sutures in the world that can hold pressure. So imagine if we do an abdominal incision on a 600-pound patient. Do you think a staple can hold that skin together when we close it?
No.
No way. So for those patients, they most likely will have retention wires, sutures, which are temporary. Of course, we'll take them out after a week, but these are special considerations. The important thing here is to identify when it occurs. So dehiscence, obviously, there's partial or complete separation of the wound of the incision. So they opened up. Evisceration, obviously, is you see pieces of bowel now coming out through that opened incision. And as stated here, is that good to see a piece of bowel peeking out, saying hi to you?
No.
No, that is a surgical emergency. So what do we do with that? And these are the patient's complaint. Okay, this is the description. Something popped, or I felt like I split open. So we have I'll come back to this part because the management is here. I just don't want to miss it. It's farther than I thought. Okay, I don't know why they put this so far. Okay, chart 16-6. This is what you do when you see wound evisceration. What's the first action?
Contact the surgeon.
Contact the surgeon.
Alright. You can't really reach the surgeon on time, so it's better if you do rapid response. It can come sooner. So just yell for help because you can't leave the patient. Look at number 2. Never leave the patient. All right, stay with the patient. It's a scary episode, and you can maintain safety if you stay with them. Because if you leave them, who knows what this patient will do? They might try to push that bowel back into their abdomen. They're not supposed to, because you can't contaminate that. So just yell for help or activate if you have some way to activate rapid response. Do so. Do not leave the patient. And then you start covering the wound. How do we cover it? So we use a sterile technique. You moisten a sterile gauze and then with sterile saline, and then you put it over the bowels and then you cover it. So right here, moistened dressings, so they have to be sterile. Put it over the exposed viscera. Do not attempt to reinsert the organ because you don't know whether or not they become incarcerated. Okay, they might get choked, and then the piece of bowel may lose blood supply, and then it'll turn necrotic. Then we'll have another problem. And then place the patient. So how do you reconcile this 11 and 12? You put the patient with the hips and knees bent, but you can't raise the bed higher than 20 degrees. What do you call that position?
Dorsal recumbent?
Semi-Fowler.
Semi-Fowler.
That's Sims.
No. Dorsal recumbent.
30.
Dorsal recumbent is correct.
Oh, okay. Lit.
And read the rest of it. You can read, right? Thank you so much. Let's go back to wound care. All right, any questions up to this point? Alrighty then. Drains. The important thing about drains is to keep them patent, to keep them flowing. The purpose why that surgeon left the drain is he expected a lot of leftover drainage, meaning he expects some bleeding inside, or in the case of a gallbladder surgery, for instance, there might be leaking of bile, so he needs to make sure that doesn't stay inside. So he needs all drainage to come out. But because you already closed the incision, we can't leave the incision open. All you can do is put a drain in there to facilitate drainage of excess fluid. Because if that fluid stays in there and then accumulates, then the incision cannot heal. Okay, and then of course, if you have anything wet down there, which is not in the bloodstream or not inside the cell, it's in between. So that can potentially promote bacterial growth. And then next thing you know, you have an infection. How much drainage is reportable? Okay, so the best thing to do is to monitor the progression of the bleeding. So if you see some bleeding on the dressing, and the rule is, you know this from fundamentals, that the first surgical incision must only be changed by the surgeon or the surgeon's designee. By designee, I mean there's a surgical team, a team of surgical students, for instance, they make rounds, so they can change the dressing. But nurses must not change the first surgical dressing. So all we can do is monitor the amount of drainage. So we can do it by outlining it with a pencil. Why only a pencil? Why not a Sharpie?
Because wouldn't that seep in?
Exactly. So that's a recommendation by the Wound Ostomy Care Nurses Association, that we should not use any ink, because ink can absorb and seep into the, the wet drainage and then contaminate the incision. So we can only use a pencil. There are various dressings. This one's an old Montgomery strap. This is very old, but still very useful today. Gives the patient very good assurance. They feel that the dressing is secure, especially if it's an abdominal dressing. Although this is not commonly used, but I appreciate the time that we were using these. It's been a while since I've seen them. These are your common drains. We have a Penrose, a T-tube, a JP, and a Hemovac. Obviously, these two don't have any suction. They're just draining by gravity. They're just left in place. The important thing to note with a Penrose is don't let it slip back into the wound, because half of it is inside the wound. A small portion is protruding outside. The problem is if this thing, you lose it, okay, it retracts back into the incision, then you're gonna have to dig it out. Of course, you can't do that. The patient has to go back to the OR to dig it out. So your important responsibility for that is to put a safety pin on the part that is protruding. That way it doesn't retract into the incision. T-tubes are fine. Surgeons will just simply pull these out when it's time. So this part is sticking out of the patient, and this one is in the biliary tree. Okay, this is used for gallbladder surgeries. The JP, has a suction, not active suction. It has passive suction, or the proper term is self-suction. So you compress the bulb before you close the top, and it will apply some suction to the surgical site. That way it will um, facilitate the drainage of the fluid. This one obviously has larger suction because the size is bigger. This is smaller. This is only about 120 ml capacity. This one can hold up to 250 or sometimes 300, but of course we never wait for it to fill that much. We already empty it because it loses suction if there's too much drainage inside. So this thing acts like an accordion. So similar to this one, because of the large capacity, it has higher suction compared to JP. JP is typically used for, depending on how much drainage you're expecting. So this is common after gallbladder surgery. So this is attached to the T-tube sometimes. And some spinal surgeries also, they use this. But larger surgeries like joint surgeries, especially knees and hip surgeries, use a hemovac. Or there are also sterile, self-containing drainage devices wherein they use it for auto transfusion. This one is not sterile. Well, it was sterile when we inserted this into the patient's incision, but over time, of course, because there's nothing in here to keep it sterile, so we can't use this to retransfuse the patient's blood. Opioids. So since we're using a lot of opioids post-op, we have to know safety. Pain management was discussed in NUR 200. All I'm doing here is the management of overdose, which is covered under chapter 16. Before that, let's do our routine laboratory assessment. So post-op, so we're looking for bleeding, we're looking for signs of infection, we're looking for kidney function. All those can be monitored through blood. So you'll draw a complete blood count, chemistry. Oh, I forgot electrolytes also can be monitored there. So we have hematology and chemistry is drawn. Sign of infection is called left shift or bandemia. It's a long story to get to left shift, but let me just explain bandemia. Bands are immature neutrophils right here, band cells. Segmented neutrophils are mature neutrophils. Since neutrophils are the types of white blood cells that fight bacterial infection, so if your band neutrophils increase, that indicates a bacterial infection. So whenever you hear this term, left shift, again, I'll tell you another day how that term came about. This is a long story. Left shift is also called bandemia. Either way, that indicates a bacterial infection. As already mentioned, we monitor kidney function. Again, already mentioned in table 16-1. And electrolytes also. Okay, we monitor electrolyte levels. This is now respiratory. You learned about incentive spirometry, right? From some fundamentals of nursing.
Yeah.
Okay. Please make sure you know how to use it. Don't embarrass yourselves by teaching the patient the incorrect way. How do we use a incentive spirometer? A, do we blow into it? B,
No.
do we
Inhale.
inhale through it really fast?
Like a big yarn.
You have
Okay,
to do it slow.
all right. So you
Slowly.
inhale slowly and deeply. All right. How often do we use an intensive spirometer?
10 times an hour. Wow, wait.
Okay, 10
10.
times every waking hour. Very good. All right. Besides opioids, we also give the patient benzodiazepines. Benzos are chillaxing medications, like lorazepam, midazolam, uh, diazepam. Okay, so those are Versed, Ativan, and Valium. We may end up having an overdose because it happens with, let's say we were careless, we didn't monitor the patient's kidney function before giving the next dose. So the kidneys aren't able to normally excrete the drug, and then we gave another dose, so it tends to accumulate in the bloodstream, and then the patient
Hello?
no for an
Can you hear
opioid
you,
over.
Professor?
I'm sorry.
Oh, I thought you were talking.
You were just. You cut out a little bit.
for a minute.
Okay. I was saying, do not use the wrong antidote for the wrong drug. Flumazenil is for benzos. Narcan or naloxone is for opioids. Okay, they are not interchangeable. So if we compare 16-4 with 16
Professor, I have a question.
16 something with opioids somewhere here.
Professor, I have a question.
Go ahead.
Is it bad when they suspect like an overdose and they give Narcan?
Why is it bad though? Oh, what overdose? Benzo or opioid?
No, like the Narcan for opiates.
Why is it bad though?
No, I'm asking you.
Oh,
Like,
we
if
mean,
I think she's asking, like, would there be a bad effect, like a negative effect?
yeah, like let's say like they didn't do it, but it's like a suspected overdose and they give it. Would that affect them in any way?
well, that's good because we're saving the patient's life.
Okay.
Oh, no, Mr. Scott, I think you're not understanding what she's saying.
What is it?
She's
She's
saying,
saying that, like, somebody comes in comatose and they suspect that it's an overdose, so they give them Narcan, but that's not really what it is. Is there an adverse effect to that patient?
Oh, no.
Okay.
Look, as you can see, Narcan has a very short half-life. Look at this. This is for opioid. This is the dose. 0.4 milligram is the standard. You can give up to 2 milligrams. So it's repeated 2 to 3 minute interval. So how long does the drug last?
2 to 3
2 to
minutes.
3
2 to
minutes.
3 minutes.
Only. So it has a short half-life.
Oh, okay.
So if any, is very little harm. Okay. One thing to remember though, if you're giving Narcan, the drug reverses the whole thing. So if the patient had pain and you gave opioids, what will happen to that pain level if you give Narcan?
Comes right
It'll
back.
go away.
Okay, so just bear in mind that that's possible. Okay, and then after that, you may have to give the patient opioids again. All right. But what can we do? I mean, it happened. So just be careful the next time that you end up giving too much. Always consider kidney function. Anyway, while we're here, I'll go back to the flumazenil after this one. So we're already here. So these are the routes. You know that we do this in the community now. So there's a spray form available. Important thing here is because this thing induces nausea. Here, it can talk. This is nausea and vomiting, and the patient already was still drowsy when you gave the Narcan, right? So they could aspirate if they end up vomiting. So after giving Narcan, make sure their head of the bed is up, their heads are turned to the side, and do not leave the patient until they're fully responsive. Plus, most likely when you give oxygen, this is already a mask. See, it's 10 breaths per minute. I'm sorry, you're giving oxygen, right? So it's not cannula anymore because the patient's respiratory rate is 10. So nasal cannula won't cut it. And if you put a mask and then they vomit, that's a sure thing for aspiration there. Okay, so just be careful with Narcan. So if you look at this chart, it's really identical. Let's compare it to flumazenil. Back here on right here. So in benzo overdose, the same thing. The drug, of course, is different from flumazenil. So you still have 0.2. The Narcan was 0.4 to 2. This one 0.2 to 1. Still the same. You repeat 2 to 3 minutes. So therefore, it has a short half-life too. Give oxygen, the same thing. And it still triggers vomiting. Okay, so it's identical. So there's not really a lot to memorize, but it's better to understand. That way you don't have to memorize. Okay, so both agents are designed to reverse the benzo and the opioid respectively. Oxygen, you should know. Breathing exercises, we did this in fundamentals. There will be some examples also here. We, as much as possible, we get the patient out of bed as soon as we can. Post-op day 0, hopefully. If not, post-op day 1 at least. Until they ambulate though, don't forget, we discussed this in chapter 14 with the surgical care improvement project that we perform leg exercises, the stockings, the compression devices to prevent DVT. Right? We'll discuss this further in chapter 36. All right, so we did, okay, skincare. This one is nice to know. I don't want to test it again because this is redundant. However, they put this here because majority of your patients who undergo surgery are over 65. Okay, so this is the reason why we change a wet dressing. So that's why if the dressing is saturated and it's the first surgical dressing, you're supposed to call the doctor because we don't want a wet dressing. They grow things, so it can cause an infection. Here's a practical advice on removing sutures. Staples and sutures also. When it comes to staples, please do not remove them consecutively. So it should be every other. Okay, so you remove let's say there are 20 staples. So you remove the second and the fourth, the sixth, and so on. That will make sure that in case this, especially if the patient's obese, okay, in case because we typically take it out 5 to 10 days. Sometimes the patient is diabetic, for instance, or the patient has poor nutrition, they're malnourished, so they're healing, or maybe they're on steroids, for instance, for whatever reason. So their healing time may be a little bit delayed. So consider that when you remove staples, make sure it doesn't open. Okay, so you may have dehiscence. So we'll just, if that happens, we'll just give them a couple more days to heal. Okay, of course, you notify the physician why you didn't remove the staples. But the important thing is somebody makes sure that the staples were not removed yet. I once had a short stint, 2 years in home health. I visited a patient who we forgot to remove staples. It's been already 4 weeks since the patient's surgery. So when I went to visit the patient, the staples are gone because the skin has already grown over the staples. So the patient had to be taken to the surgeon in order to cut the skin in order to find the staples, because again, the skin has already grown over them. You couldn't tell because again, there's no sign of a staple anymore. The skin has grown over it, but since there was no record of the staples ever been taken out, so we had to report it, and which is a good call because the staples were there. Okay, we already discussed JP's Hemovax. We did drug therapy. Drug therapy are opioids. That's why we have the opioid overdose there. And then we did this already. And what is this? Oh, nasogastric tubes may be necessary if the patient has severe symptoms. It's routinely done for open abdominal surgeries because the doctors anticipate that the patient will be miserable. They'll have severe nausea, vomiting, abdominal bloating. So they'll put the NG tube in the OR. It's kind of funny really because instead of the patient being conscious, since the patient can't tell you or they can't swallow the tube because they're still unconscious, while the patient is the patient's abdomen is still open, they put the tube in and then they feel the tube inside the stomach, which is kind of cool, but you're sure that it's in there because you can touch the tube. Anyway, the purpose of the tube is to decompress the stomach, so no vomiting, no nausea. So because again, we're expecting low peristalsis or even no peristalsis after surgery. So they need stomach decompression to stay comfortable. Plus, you don't really want a patient vomiting with a big abdominal incision. You're familiar with hydromorphone? It's still an opioid, still from the opium family, but this thing is at least 5 times stronger than morphine. So please consider that when you're using this. If your patient is ordered hydromorphone, which is dilaudid, keep that in mind. Okay, so be conscious about how much you give. So these are your choices: codeine, oxycodone. So these are the pills. So you have morphine, IV, and hydromorphone. The rest of these are PO, except this one. Ketorolac is a IV NSAID. It's an NSAID nonetheless, so all NSAIDs, you monitor kidney function, as well as GI bleeding. These things can cause ulcers and cause them they might bleed. Did you discuss PCA in NUR 100?
Yep.
Okay, so you understand how it's done, right?
Yes.
Yes.
Yeah, we learned it in math for meds.
Okay, very good. Can a paraplegic use a PCA?
No,
No.
Why
because they
not?
can't press the button.
Yes.
Well, yes, the hands.
You said paraplegia, so yes.
Yes. Using them.
Okay, let me turn it to a quadriplegic. Can they use it?
Yes. But
Don't they have like a special device for them or something like that?
Okay, very good. So please do not deprive a quadriplegic of a PCA, okay? It's not a requirement that they have to literally push a button because there are other ways to activate it. All right, is that clear? So the only contraindication for a PCA is if the patient doesn't know how to use it.
what's
Like
the
the
other
patient
way, I'm sorry, what's the other way that a quadriplegic can use it?
we have blow switches now. So instead of pushing the switch, you blow into a straw.
Oh wow, thank you.
Okay. So again, the only contraindication is if they have dementia or any other cognitive limitations, or an unconscious patient, because you can't have, remember there's a PCA by proxy. Is that allowed? Like a family member presses it for them?
No.
No.
No. The only contraindication is if the patient doesn't know how to use it, okay, or is incapable of using it. But having no arms or no fingers is not a contraindication. Just like how there's no contraindication for you to stick your finger up somebody's butt to do a rectal disinfection. All you need is a finger and a rectum. If you have both, then you can do it. Here's a
have-
warning. I'm sorry.
I'm sorry. What if they have hemorrhoids? You can still do it then?
Yeah, just don't do it forcefully.
Okay.
It's gonna be painful, but okay. Here's a warning with elevating the legs because you want to promote circulation, venous return. Don't do it behind the knees, okay? Because there are arteries and veins there, so you're going to restrict circulation actually. Like I said, we'll discuss DVTs extensively in chapter 36. I'm almost done and then you on a break. This part here is again part of chapter 36, our number one prevention for DVT, or the number one way to manage DVT is to prevent it in the first place. Because we're not always good with the identifying it. We may miss it, and then next thing we know, the patient's dead overnight because they threw a clot and we had no idea. We thought they were sleeping. Here are a few practical examples. Please be careful, because these are all part of managing complications. So the questions can come from any body system. So for instance, if you're asked about how do you manage post-op nausea, vomiting, or post-operative ileus. So here's gum chewing. Gum chewing has been known to promote peristalsis. Okay. Okay. And let's do discharge teaching. So what do you teach about a patient who is post-op? There you go. Please make sure the patient knows when to follow up with their surgeon. Nutrition, definitely, unless there's a contraindication, they need what type of diet in order to promote wound healing?
Protein.
All right, protein doesn't have to be steak, okay? Could be eggs, bacon, okay? Bacon is protein. Milk is protein, right? Unless, again, there's contraindications. Let's say they have heart failure, then don't use bacon. Care of the incision. Most of our incisions now have long-term dressings, let's say knee and hips, because those are our common surgeries. They have 7-day or even 10-day dressings now. So just make sure the patient understands them. They are fully waterproof, so there's no problem with them taking showers. Okay, so here's your diet to promote wound healing, and then we have here activity. So they typically are cautioned against returning to pre-surgery activity levels yet. So they can't do that. If they increase activity, it should be done gradually and slowly. But anyway, the surgeon will specify what activity restrictions there would be. And that's it. Questions on a post-op patient?
Professor, can I ask you about the quiz next week?
Yes, it will be all that we did today. If we're still not done, we still have chapter 17 after the break. But I'll only do the quiz on 14, 15, and 16.
14 through 16.
Yeah.
And are we only focusing on what we talked about in class? I mean, you did mention like read these portions, but what exactly do we focus on is basically my question.
So basically, it's forcing you to. I won't tell you what questions will be in there. I want you to prepare for the exam early. All right.
Great. So just chapters 14 through 16.
Yeah, get used to it. For
Professor.
this class, okay.
Professor?
Okay, thank you.
Yeah, I'm the most unpopular instructor.
That's not true, Mr. Escarter.
What is it, Miss Cheney?
I said that's not true.
No, I mean popular in a not in a good way, you know.
I know.
Yeah.